Welcome back to the Deep Dive. Today we are tackling a really challenging topic, but one that's absolutely crucial, renal failure.
Yeah, it's dense stuff, but so important. We're focusing on acute kidney injury, AKI, and chronic kidney disease, CKD, pulling from Porth's essentials.
Exactly. Our mission today is basically to cut through some of that density, get to the core ideas, the mechanisms, and really understand what happens when kidneys fail, acutely versus chronically, make it accessible.
And fundamentally, renal failure just means the kidneys aren't doing their main jobs. They fail to filter out those metabolic wastes from your blood.
Right. And they can't regulate the body's fluid, electrolytes, or pH balance properly either. Everything starts to go off kilter.
That's the core issue.
And the big distinction we need to keep in mind is timing and reversibility, right? AKI hits fast hours to a day, and, well, it might be reversible.
Potentially. But CKD, that's different. It's the slow burn, the end result of damage that just adds up over time, often quietly.
It's kind of shocking, that point from Porth's about CKD. You often don't see symptoms until something like 80% of nephrons are already gone.
It really is staggering. That huge functional reserve hides things for way too long.
Okay, so let's unpack this, starting with the immediate danger, acute kidney injury.
Right, AKI. It's that sudden drop in kidney function. We're talking hours, maybe a day.
And the telltale sign is azotemia.
Exactly. Azotemia. That's the buildup of nitrogenous wastes, urea, uric acid, creatinine in the blood because the kidneys just aren't filtering properly. Your GFR, the glomerular filtration rate, tanks.
And the outcomes can be pretty grim. The mortality rate you see cited, like 15 to 60%, it's high. Why hasn't that improved much?
Well, it's often because AKI isn't really the primary problem people are admitted for. It tends to ride on the coattails of other major insults.
Like a complication.
Precisely. It's often superimposed on really severe stuff: sepsis, shock, major trauma, sometimes drug toxicity. You're dealing with a critically ill patient, and then their kidneys fail on top of it all.
Makes sense. So to figure out why it's happening, we usually classify AKI based on location, right? Prerenal, intrarenal, postrenal.
Yeah, those three buckets cover most cases, like 80 to 95%. And the most common one is prerenal.
Prerenal, so before the kidney. This is about blood flow.
Exactly. It's a perfusion problem. The kidney tissue itself might be fine initially, but it's just not getting enough blood. Think massive bleeding, severe dehydration, heart failure.
Cardiogenic shock, sepsis, situations where the circulation's compromised.
Right. The kidneys are starved.
And there's that diagnostic clue you mentioned earlier, the BUN to creatinine ratio. Can you explain that again? How does low blood flow cause that specific change?
Sure. So when the kidneys send slow flow, they go into conservation mode. They try desperately to hang on to sodium and water.
Okay.
And as they reabsorb more water, they also passively pull back more urea from the filtrate because it's small and diffusible. But creatinine, it's larger, less easily reabsorbed.
So urea gets reabsorbed disproportionately compared to creatinine.
Exactly. So the BUN level in the blood climbs much faster than the creatinine level. You get this ratio greater than, say, 15.1 or even 20.1. It screams prerenal.
That's a neat diagnostic trick, but it's also a bit alarming that some common drugs can cause this too.
Yes, that's a really important point. Things like NSAIDs, ibuprofen, naproxen, also ACE inhibitors, even certain IV contrast dyes used for imaging.
How do they do that?
They can trigger intense vasoconstriction inside the kidney, clamping down on the blood vessels supplying the glomeruli. It mimics a low flow state, even if the person's overall blood pressure is okay.
Wow. Okay, so that's prerenal perfusion failure. What about intrarenal AKI, damage within the kidney?
Right. This means the kidney structures themselves are injured. The most common cause here is acute tubular injury, or ATN, acute tubular necrosis.
Necrosis meaning cell death.
Yes. Usually happens after prolonged ischemia, like if prerenal AKI goes on too long, and the kidney cells actually start dying from lack of oxygen or exposure to toxins.
Which toxins are common culprits?
Certain antibiotics, especially aminoglycosides, like gentamicin, are classic examples. Also, the same radiocontrast media we just mentioned.
Why are the kidneys so vulnerable to these toxins?
Because it's their job to filter and concentrate substances. So they end up concentrating these toxins to really high levels within the tubular cells.
And Porth describes this process, right? The tubular cells get damaged, swell up,
And they slough off. They basically detach from the basement membrane and fall into the tubule.
creating debris.
Exactly. This cellular debris forms casts, which then physically block the tubules. Think of it like pipes getting clogged. Filtrate can't flow through, pressure backs up.
And GFR drops even further because of both the initial damage and the obstruction.
Precisely, it's a double whammy.
Okay, and the third type is postrenal AKI. This one sounds simpler.
It generally is. Postrenal means there's an obstruction to urine outflow after the kidney, somewhere in the ureters, bladder, or urethra.
Like kidney stones.
Kidney stones, tumors, blood clots. But the single most common cause, especially in older men, is benign prostatic hyperplasia, an enlarged prostate gland squeezing the urethra shut.
And that blockage causes urine to back up.
Yeah, the pressure builds retrogradely, all the way back up into the kidneys, eventually damaging the nephrons. The good news here is, if you can relieve the obstruction quickly, function often recovers well.
So, regardless of the cause, AKI tends to follow a pattern, doesn't it? These 4 phases.
Typically, yes. You have the onset phase from the initial insult until the injury actually occurs. Then comes the often dangerous oliguric phase.
Oliguric meaning low urine output.
Right, sometimes even anuric, meaning almost no urine. GFR is way down. This is where you see waste products accumulating rapidly, that azotemia gets worse.
And fluid overload, electrolyte problems, like hyperkalemia.
Yes, hyperkalemia, hypotassium is a major life threat in this phase. Fluid overload can cause edema, hypertension. You can see neurological changes too. It's a critical time.
Then, if things start turning around, you hit the diuretic phase.
Correct. The kidneys are trying to heal. Urine output starts to climb, sometimes dramatically, like liters per day.
That sounds good, right? More urine.
It's a sign of recovery beginning, but it's tricky. The tubules can filter water, but they haven't regained their ability to fine-tune electrolyte reabsorption yet.
Ah, so you can lose too much.
Exactly. Patients can become dehydrated and lose vast amounts of sodium and potassium. You have to monitor electrolytes and fluids incredibly closely during this phase.
And finally, the recovery phase.
Yeah, where tubular function gradually returns to normal. GFR improves, often getting back to maybe 70 or 80% of baseline over weeks or months. Some function might be permanently lost, though.
So treatment boils down to finding and fixing the underlying cause, managing fluids and electrolytes like crazy, and using dialysis if needed.
That's the essence of it. Hemodialysis, or sometimes continuous renal replacement therapy, CRRT, especially in unstable ICU patients, to bridge them through the crisis.
Okay, that covers the acute emergency. Now let's shift to the slow, progressive decline. Chronic kidney disease, or CKD. And the numbers here are huge, right? Over 20 million adults in the U.S.
Yeah, the prevalence is massive and probably underestimated. This is where things get really complex because it affects, well, basically everything.
So how is CKD formally defined? It's not just about GFR dropping suddenly.
No, it's about duration. The National Kidney Foundation guidelines define it as either evidence of actual kidney damage, like protein in the urine, or R, a GFR less than 60 LLMN 1.73 mL/Nort that persists for 3 months or longer.
3 months is the key time frame. And kidney failure is when GFR drops below 15.
Right, GFR below 15, or when someone actually needs renal replacement therapy like dialysis or transplant. That's end-stage renal disease, ESRD.
And what are the main drivers behind CKD in the U.S.?
Overwhelmingly, it's hypertension and diabetes. Uncontrolled high blood pressure and high blood sugar just hammer the delicate structures in the kidneys over years.
So GFR is the best measure of overall function. How do we estimate that?
We calculate it usually using formulas like the MDRD or CKD EPI equations, which factor in serum creatinine level, age, sex, and race. But creatinine alone isn't perfect, especially early on.
Right. So what's a better early warning sign of actual damage?
Albuminuria. Protein, specifically albumin, leaking into the urine where it shouldn't be.
And that's where microalbuminuria comes in.
Exactly. Detecting small amounts microalbuminuria, defined as 30 to 300 milligrams of albumin per gram of creatinine, is a key early indicator, especially for diabetic kidney disease. It signals the filters are starting to break down.
And as this breakdown progresses, as more nephrons are lost, we move from just azotemia, the biochemical finding, to actual uremia.
Yes. Uremia is the clinical syndrome. It's when the accumulated waste products start causing symptoms throughout the body.
What kind of symptoms are we talking about?
Oh, it's systemic. Weakness, fatigue that's just bone deep, nausea, vomiting, itching, metallic taste, confusion, shortness of breath. It affects almost every organ system.
Let's dive into some of those systemic effects. One of the really complex ones is the CKD mineral bone disorder, or CKD-MBD. It's this whole cascade involving phosphate, calcium, vitamin D, and the parathyroid gland. Can you walk us through that?
Okay, simplified version. Healthy kidneys get rid of excess phosphate and they activate vitamin D.
Got it. Phosphate out, vitamin D on.
When kidneys fail, phosphate builds up in the blood, hyperphosphatemia. At the same time, they stop activating vitamin D.
So high phosphate, low active vitamin D.
Right. High phosphate tends to bind with calcium, lowering free calcium levels in the blood. And low active vitamin D means you can't absorb calcium efficiently from your gut.
So blood calcium drops.
Yep, hypocalcemia. The body senses this low calcium and reacts by pumping out more parathyroid hormone, PTH.
Trying to raise calcium levels.
Exactly. PTH's main job is to pull calcium out of the bones to maintain blood levels. In CKD, this becomes chronic and excessive. It's called secondary hyperparathyroidism.
And the result is bone disease. Renal osteodystrophy.
Yes. The bones get constantly remodeled or weakened. You can get high turnover disease, where bone is resorbed too quickly, or low turnover disease, where it's not built properly. Things like osteitis fibrosa, osteomalacia.
And this isn't just about fragile bones, is it? There's a huge cardiovascular link.
Absolutely crucial link. That excess calcium and phosphate floating around doesn't just stay in the blood. It starts to deposit in soft tissues, especially blood vessel walls.
Vascular calcification.
Yes, it makes arteries stiff, contributes to hypertension, heart valve problems. CKD-MBD is a major driver of the incredibly high cardiovascular mortality we see in CKD patients. Bone health is heart health here.
Wow. Okay, moving to the blood itself. Anemia seems almost universal in advanced CKD.
It is. Profound anemia. Hemoglobin often drops below 12 GDL in women, 13 in men. The primary reason is the failing kidneys stop producing enough erythropoietin.
EPO, the hormone that tells the bone marrow to make red blood cells.
That's the one. Without EPO, red cell production grinds to a halt. There are other contributing factors like iron deficiency and inflammation, but lack of EPO is central.
And that anemia puts a huge strain on the heart, right?
Yeah, definitely. The heart has to beat faster and harder to deliver enough oxygen to the tissues, leading to increased cardiac output. Over time, this contributes to left ventricular hypertrophy, thickening of the heart muscle, and eventually heart failure.
Plus, hypertension is usually already present or gets worse.
Yes, hypertension is both a cause and a consequence of CKD. It absolutely must be controlled aggressively.
And certain blood pressure meds are preferred.
ACE inhibitors and ARBs are often first line, especially if there's proteinuria. They do more than just lower systemic BP. They seem to reduce the pressure inside the glomeruli themselves, which helps protect the remaining nephrons.
Slows the progression. Okay, what about the nervous system?
CKD hits the nervous system too. Peripheral neuropathy is common. Patients complain of restless legs, burning feet, numbness, tingling.
And centrally?
In advanced uremia, you can get uremic encephalopathy. That ranges from reduced alertness and difficulty concentrating to confusion, seizures, coma, and that characteristic flapping tremor called asterixis.
Asterix is right. And one last really practical point. Drug elimination.
Hugely important. Kidneys clear so many medications and their breakdown products. When they fail, drugs can accumulate to toxic levels very easily.
So dosages need careful adjustment.
Absolutely. And you have to be incredibly cautious about over-the-counter stuff, too. Things containing magnesium or potassium, which failing kidneys can't excrete, can become dangerous quickly.
Okay, so CKD is this multi-system monster. How does it play out differently in, say, children versus older adults?
Good question. The causes and consequences can be quite distinct at the extremes of age. In young children, especially under 5, CKD is rarely due to diabetes or hypertension.
What causes it then?
It's much more likely to be congenital problems, things they were born with, like kidneys that didn't form properly, renal dysplasia, or blockages in the urinary tract, obstructive uropathy.
And the impact on a growing child must be devastating.
It is. You see severe growth impairment, developmental delays are common, and their bone disease, that CKD-MBD, tends to be really severe, often the high turnover type.
So treatment priorities are different.
Yes. Because of the profound impact on growth and development, early renal transplantation is often the preferred approach for children with kidney failure, if possible.
Now, what about older adults? We know kidney function naturally declines with age.
It does. GFR tends to decrease steadily after about age 40. This normal decline makes older adults more susceptible to kidney injury from other causes, like dehydration or nephrotoxic drugs.
And diagnosing CKD can be trickier in them. You mentioned creatinine earlier.
Right. Serum creatinine level depends partly on muscle mass. Older adults typically have less muscle mass, so their baseline creatinine might be low.
Meaning their GFR could be quite low, but their creatinine level might still look normal or only slightly elevated, masking the severity of the CKD.
Exactly. It's a diagnostic pitfall. You really need to calculate the estimated GFR using those formulas.
And treatment in this group.
It has to be highly individualized. You're balancing the potential benefits of interventions against the risks, overall health status, and crucially, the patient's quality of life and goals of care.
But age itself isn't necessarily a barrier to treatment, including transplants.
No, age alone shouldn't preclude treatment options like dialysis or even transplantation if the person is otherwise a suitable candidate. It's more about their overall physiological state than their chronological age. Hashtag tag outro.
Okay, let's try and bring this all together. A huge amount of information here.
It really is. But the key takeaways. AKI is the sudden hit think pre-renal flow, intrarenal damage, or postrenal blockage. It's potentially reversible if caught early and managed well.
Right, while CKD is the long, slow decline defined by reduced GFR or kidney damage over at least 3 months.
And CKD leads to those widespread systemic problems: uremia poisoning the body, CKD MBD wrecking bones and arteries, anemia straining the heart. The list goes on.
Treatment for CKD focuses on slowing down that progression, controlling blood pressure, blood sugar, maybe using those ACE inhibitors or ARBs, or ultimately renal replacement therapy.
Dialysis or transplantation.
So here's something to think about, building on what we discussed. We know the kidneys have this incredible reserve, masking CKD until maybe 80% of function is lost. Given that, how can clinical practice better leverage those really early warning signs, like microalbuminuria, to catch this process much, much earlier, long before uremia sets in? How do we maximize that window to intervene and potentially slow down the relentless progression?
That's the million-dollar question, isn't it? Early detection and intervention are key.
Definitely something to ponder. Thank you for joining us on this deep dive into the complex world of kidney failure. We hope breaking down AKI and CKD this way has been helpful.